In this video, we will cover narcolepsy. Narcolepsy is a chronic neurologic disorder caused by the brain's inability to regulate sleep-wake cycles normally and characterized by abnormalities of rapid eye movement sleep, some abnormalities of non-rapid eye movement sleep, and also excessive daytime sleepiness. At various times throughout the day, people with narcolepsy have uncontrollable urge to sleep. Patients with narcolepsy often go directly into rapid eye movement sleep from wakefulness. This is a unique feature of narcolepsy, and this does not occur in normal sleep. Patients with narcolepsy also have fragmented and disturbed nighttime sleep. Narcolepsy is divided into three types: narcolepsy with cataplexy, without cataplexy, and secondary. Cataplexy is a brief and sudden loss of skeletal muscle tone. It can manifest as a brief episode of muscle weakness or complete postural collapse and falling. The first type is with the cataplexy, that is a sudden muscle weakness or total loss of muscle control. The second type will be without cataplexy, that is continuous excessive sleepiness but no cataplexy. The secondary is due to injury to the hypothalamus of the brain. Now, we'll see the pathophysiology and etiology. Recent advances suggest that this common sleep disorder may be a neurodegenerative or autoimmune disorder resulting in the loss of hypothalamic neurons that contain a peptide, that is hypocretin or orexin. Hypocretin plays a central role in the timing of sleep and wakefulness and inhibit rapid eye movement sleep. The deficiency in hypocretin contributes to the abnormalities of sleep and wakefulness in narcolepsy. Genetic susceptibility associated with the class 2 human leukocyte antigens. Although considered a hypersomnia disorder, the person does not experience excessive amounts of sleep in a 24-hour period. Typically, patients with narcolepsy have a normal amount of sleep over 24 hours. They have abnormal rapid eye movement sleep that intrudes into wakefulness. Onset is usually between ages 15 and 25. The clinical manifestations are: the onset of narcolepsy typically occurs in adolescence or early in the third decade. Head trauma, a sudden change in sleep-wake habits, and infection may trigger the onset of narcolepsy symptoms. There are 4 classic symptoms, but all symptoms not present in all patients. Excessive daytime sleepiness is usually the first symptom. Cataplexy, abrupt loss of muscle tone after emotional stimulation such as laughter and anger. Sleep paralysis, powerless to move limbs, speak, open eyes, or breathe deeply while fully aware of condition. The patient may have hypnagogic hallucinations, drowsiness before sleep, usually visual or auditory. Symptoms may be enhanced by high temperature, interactivity, and idleness. Clinical manifestations may abate but never phase out completely. Patient may complain of inability to focus vision or thought process rather than having a feeling of sleepiness. Nocturnal sleep disturbances occurs 2.5 to 3 hours after falling asleep. After being awake for 45 to 60 minutes, the patient will fall back to sleep for another 2.5 to 3 hours and then awaken again. This is believed to be the source of the daytime somnolence. Somnolence is defined as the state of drowsiness or strong desire to fall asleep. Now we'll see diagnostic evaluation. Narcolepsy is diagnosed based on a history of sleepiness. An overnight polysomnogram is a sleep disorders lab is included in the evaluation to assess nighttime sleep and indicate underlying cause for the complaint of sleepiness. The polysomnogram helps evaluate sleep quality and excludes other disorders such as sleep apnea. The polysomnogram is followed the next day by a multiple sleep latency test to assess daytime sleepiness, indicates severity of the problem. Patients are given 4 to 5 opportunities to nap every 2 hours. Narcolepsy cannot be cured completely, so the management is focused management of common symptoms: excessive daytime sleepiness, nighttime sleep disturbances, and catalepsy. Provide teaching about sleep and sleep hygiene. Long-term treatment is required. Mutual goal setting is imperative because not everyone derives benefit from treatment. Even with medication, patients may never attain normal levels of alertness. Non-pharmacologic therapy includes support groups, short naps, 10 to 20 minutes, 3 times daily caffeinated beverages, exercise, sleep hygiene techniques, and avoidance of heavy meals are included in management of narcolepsy. Modafinil, that is Provigil, and armodafinil, Nuvigil, are non-amphetamine wake promotion drugs that are considered a first-line drug therapy. Sodium oxybate, that is serum, a metabolite of GABA, is another wake-promoting medication that is effective for treating both daytime sleepiness and catalepsy. Antidepressants are used to treat catalepsy. Tricyclic antidepressants used to be commonly used, but selective serotonin reuptake inhibitors are becoming favored for the management of catalepsy. The main complications of narcolepsy are injury related to falling asleep, psychosocial problems such as disturbed relationships, loss of employment, and depression. Now we'll see the nursing interventions. First, nursing interventions for promoting normal sleep-wake cycles. We have to address the patient to wake at the same time daily. Help the patient establish non-drug therapies such as exercise, diet that will fit into lifestyle. The bedroom should be dark, cool, and quiet to facilitate sleep. Administer or teach self-administration of prescribed medications. Advice of adverse effects of amphetamines such as nervousness, irritability, tremors, and GI upset. Warn the patient to take only as prescribed and not to increase dosage because of tolerance and drug dependence. Schedule 10 to 20 minutes rest periods 2 to 3 times per day. Help the patient incorporate naps into lifestyle. Encourage the patient to incorporate small amounts of caffeinated beverages at intervals and smaller, more frequent meals rather than large, heavy meals during the day to maintain energy. Plan diversional activities and relaxation during fatigue periods. Nursing interventions for strengthening coping. Encourage active participation in selection of treatment modalities. Assist the patient in identifying trigger factors worsening symptoms. Teach problem-solving strategy to promote sense of control over activities and symptoms during the day. Review patient coping mechanisms and reinforce positive ones. Assist the patient to discuss the information about narcolepsy with friends, family, schools, and employees to help reduce anxiety and or embarrassment about his or her condition. Encourage the use of support groups and community resources. Patient education and health maintenance. Review the normal sleep cycle and pathophysiology of narcolepsy. Stress the importance of non-pharmacologic measures as an adjunct to treatment. Inform the patient of rights of employment conditions. Advise caution with using alcohol, working with machinery, or using dangerous equipment to prevent injury to self or others during sleepiness or catalepsy. If the patient drives, advise using caution and avoiding lengthy trips. Encourage the patient to wear a medical alert bracelet. Encourage follow-up with healthcare provider, specialist, and mental health counselor as needed. Here we conclude narcolepsy.